Good afternoon, and thanks for joining us for today's webinar. A couple housekeeping notes before we begin. In this platform, all attendees are muted. While you can't ask questions through audio, please note the Q&A function on your screen. If you have a question that is not addressed in the presentation today, please submit through the Q&A feature, and our presenters will try to answer as many as possible at the end. Also, today's session is being recorded. As a registrant of today's webinar, you will receive an email with a link to view the recording once it's available. Please note this may take 7 to 10 business days to post. It is now my pleasure to introduce our speakers for today. Next slide. Dr. Argate Green is a thoracic and esophageal surgeon with University Hospitals. He is also a clinical assistant professor at Case Western Reserve University School of Medicine. Dr. Catalina Tiba is a pulmonologist in our Division of Pulmonary, Critical Care, and Sleep Medicine at University Hospitals. She is also an assistant professor at Case Western Reserve University School of Medicine. And finally, Dr. Benjamin Young is Medical Director of Bronchoscopy for University Hospitals. In addition, he is an assistant professor at Case Western Reserve University School of Medicine. And now it's my pleasure to turn it over to Dr. Tiba to begin our presentation.
Good afternoon, everyone. Thanks for joining us. Thank you for introducing me. So I'm one of the pulmonary critical care physicians, and we're here to talk about lung nodules and lung cancer, which is my talk. Next slide, please. Next slide, please. Hopefully you all can hear me well and you're doing well at home. So what are lung nodules and why are we here to talk about them? They're isolated, sorry about that. They're isolated, well-defined cavities on chest imaging. Sometimes they're referred to as spot on the lung or coin lesions or ditzels on lung CT scans. They're less than 3 centimeters or 3 centimeters in diameter, and they're surrounded by lung tissue. They may be found incidentally from lung view of other imaging. And I want to show you a couple of images showing you lung nodules. Next. Next, please.
Can we hold on a little bit? I mean, I could go.
So here's an image showing you a lung nodule.
Just to the.
Sorry, Ben, go back.
It just says, I'm going to start.
Please mute Dr. Green.
No, that's not true. I'm going to start talking about 12:30.
So here are a couple of images showing you lung nodule. First image on the left upper, you have a rounded lung nodule since lower right lobe. You have the white area. Ben, if you could show that for them with your cursor, a right rounded area, which is a lung nodule. And the other areas around there are vessels. The left of that lung nodule, you have bones and soft tissue, and it's surrounded by lung tissue. All that black area is lung. The bottom image, you have a lung nodule that is not so smooth. It's more concerning to us the way it looks. It's irregular and it is also in the lower lung zones. It has little areas that come out. Those are called striations, and that's an abnormal and very concerning lung nodule. Lung nodules altogether not normal in the lungs, but some are less concerning than others. Next slide, please. So pulmonary types, there are different types. This slide shows you that there are solid lung nodules, part solid lung nodules, and pure ground glass nodules. Please click for the next image. And here you see the pure solid lung nodules. You can see through them. Part solid lung nodules have a solid component and a ground glass component. The radiologists often measure those. And then you have solid lung nodules. You can't see through them. Next slide, please. So signs and symptoms of pulmonary nodule, oftentimes there are no signs or symptoms. Patients are usually asymptomatic. If symptoms develop, usually depends on the cause of the lung nodule and the extent of the involvement. Is the patient having an infection causing a cough? Is the lung nodule obstructing the airway causing wheezing, etc.? Usually they're unknown until imaging because that's how we diagnose them. And the imaging that can find them is chest x-ray, CT chests, or other imaging that obtains images from the lung. On x-ray, they have to be bigger, 1 centimeter, than how big they have to be found in CT scan, because the CT scan shows very detailed imaging of the lungs. Most lung nodules are benign, but they may be early lung cancer, which is why we get worried about them and want to follow them up. So if they're identified, it's really important to follow them up. If they're solid lung nodules, we usually follow them for 2 years. And if they're ground glass, we like to follow them for 5 years usually. Next slide, please. So what causes pulmonary nodules? There can be benign cause and malignant causes. Benign causes are usually from small nodules, or benign causes usually are small lung nodules. Smooth, they're dense, solid. Malignant nodules, we get more concerned as they're bigger. So more than 1 centimeter, also more than 10 millimeters, same thing. Irregular spiculated, non-solid ground glass. Next slide. And here you see a list of causes of benign and malignant lung nodules. Benign can be granuloma, common here in Ohio, especially histoplasmosis, atypical infections, benign tumors such as hamartoma, which is formed of different tissue. You can get venous malformations, arterial venous malformations are rare, and those are just a cluster of arteries and veins. Sarcoidosis, which is an inflammatory response in the body, and nodes can be also in lungs as much as they're in your neck or other parts of your body. Malignant causes, there are different cancers that can cause lung nodules. Adenocarcinoma, very common cause of them. Squamous cell, metastases can be a cause. Carcinoid, lymphoma, and less common, small cell. Next, please. So patterns, what are the pulmonologists looking at? We're looking at calcification sometimes in addition to size and the architecture of the lung nodule. So there's some benign calcifications. If you go to see your pulmonologist about a lung nodule, they might talk to you about diffuse calcification, central calcification, the laminated calcifications, and popcorn calcifications are patterns more consistent with benign lung nodules. Patterns that are more for malignancy or cancer are stippled and eccentric. Next slide, please. So eccentric nodule up here on the left upper image. So it's just not in there, it's to the side of the lung nodule, more concerning for cancer. And then the central calcifications down at the bottom right, you have a nodule with the central area of calcification, more consistent with the benign lung nodule. Next slide. Popcorn calcifications, here's an example of a hamartoma. So even though this is a benign tumor, it may cause problems and may still need to come out and be surgically taken care of, but this is a benign pattern. Next slide, please. Why do we care about lung cancer screening? Based on data from 2015 to 2017, approximately 6.3% of men and women in the United States will be diagnosed with lung cancer at some point in their life, lung and bronchus. So we call those lung cancers. In 2017, there were estimated 550,000 plus people living in the United States with lung cancer. Next button. And bronchus cancer represents 12.7% of cancer cases in the United States. Next button. New cancer cases and deaths in the United States from 2020 estimates. So for men and women, the most common case of cancer are their gender-specific cancer. But second to that is lung cancer. So it's very common, and that's why we talk about it and try to do something to prevent it. Next button. And the deaths are primarily from cancer. The number one cause of deaths of cancer is lung cancer. So that's why we really want to do something to prevent this. Next. The trend in the United States, as you can see here, US trends in cancer deaths from 1930 to 2017 for men and females. The trends, thankfully, in the past few decades have been going down. This is after the Surgeon General warnings in the 1960s, taxes increasing. Men finally got the message that it's time to quit smoking, and so the lung cancer cases, deaths have been down. We still have a lot of work to do compared to the other types of cancers. And for females, it took them a while longer to get the message and quit, but they are also having a decline in lung cancer cases also. Next slide. Who gets lung cancer? It's more in men than women. Smoking is the leading cause of cancer. This slide shows you some other causes, such as radon and air pollution. And unfortunately, as you age, your risk increases. And if you have a family history, you're at higher risk. Next slide. Who has a better chance of survival? So this slide shows you that if we find your lung cancer sooner, you have a better chance of survival. So if we can find it localized, your chance of 5-year survival is 59%. If unfortunately it's spread, then your chance of 5-year survival drops. In fact, if you have distant cancer when it's found, you have a 5.8 chance of a 5-year survival. Overall, the image on the left is data from 2010 to 2016. And overall, it shows that the 5-year survival for lung cancer is unfortunately 20%. It's very low. Next slide, please. So the goal is to find lung cancer sooner rather than later. So we do lung cancer screening here at university hospitals. Next slide. And this is based on data from a 2011 pivotal study comparing CT scan to chest x-rays. This was a study, it's called the National Lung Screening Trial, or NLST. Multiple centers were involved in the study in the United States, comparing low-dose CT scans, or LDCT, versus x-rays. And the outcomes were 20% reduction in lung cancer deaths. And 320 people are needed to screen to prevent one death. So low-dose CT scans and lung cancer deaths. Next slide. Here you have graphs showing you the patients that were in the low-dose CT scans versus chest x-rays. The top image, the low-dose CT scans found cancer cases, and the bottom image shows you that it had lower number of lung cancer deaths if you had low-dose CT scans compared to x-rays. Next. And mention pack your history. So what does that mean? It means the measure of lifetime exposure to tobacco toxins. So basically, if you're a smoker, take the number of cigarettes packs per day times the years you've smoked. So for example, if you've smoked for 30 years, a pack per day, you're a 30-pack year smoker. Same as if you've smoked for 15 years, but 2 packs per day, it's a 30-pack smoking. Next slide. At University Hospital, we've come together and we have a wonderful lung cancer screening program. We use data based on Medicaid and the lung cancer screening trial. We screen patients, current or former heavy smokers, 30-pack years if they within the past 15 years. And we offer screening from 55 to 77 if you meet criteria for lung cancer screening. It is a preventive study, so we want to make sure that we have the right patients in screening and no recent cancer history, no recent CT, and doing well with not too many illnesses. Next slide. So why don't we include everybody? Because it's not proven to help everybody. That's why we use the study data. Next slide. We are lucky to have many radiology centers for lung cancer screening. And so wherever you are near Cleveland, you can pick your UH radiology center to get screened. Next slide. What can you expect? So if you want to talk about lung cancer screening, talk to your provider, come to us, talk about the benefits, limitations, and the risks. What we're trying to do is find lung cancer earlier when it's easier to treat. We might find other things that are surprising and we need to work those up. Those need to be discussed, the limitations of the studies. And if we do further surprises like a thyroid nodule or issues with the heart or vessel, then those things may need worked up, further testing. So it's not a simple go for a test. It's really a discussion, risks and benefits. If you're a smoker currently, we offer smoking cessation, and this is covered by most insurance companies. Don't worry, it'll be covered. Next slide. You're getting a low dose CT scan. It is about equivalent. This slide shows you equivalent to 14 chest x-rays. It's low dose of radiation than the yearly background radiation living in the United States. It's much lower than a regular CT scan that you might get if you go to the ER with chest cough or chest pain. Next slide. So it's not a large dose of radiation. So in conclusion, lung nodules are common. There's a broad range of diagnoses. Not every lung nodule is lung cancer. Lung cancer screening saves lives if done in patients. And the NLST showed 20% mortality reduction. Close follow-up is needed. And if you do decide to go forward with lung cancer screening, it's a process. It's a screen to help prevent lung cancer. We're here to help you, and we'd love to see you in our clinics and talk further about this. Next slide. We have a wonderful lung cancer screening coordinator, Karen Mergel. Unfortunately, she couldn't be at this meeting with us today, but here's her information. There's a picture of her. Next slide. She can help you through the process if interested. And most importantly, you need to quit smoking if you're a smoker, or if you know a smoker. Encourage them to quit smoking. That's the best way to prevent lung cancer. Next slide, please. We have smoking cessation programs and the quit lines, and it's November Lung Cancer Awareness Month. So thank you for joining us today. Next slide. And I'll leave it to Dr. Young now. Thank you so much.
All right, thank you for the introduction and a very thorough review of lung nodules and lung cancer screening. Before I start, we've had a couple questions come through the question and answer session. Unfortunately, Dr. Argote Green has been answering a lot of those. Oop. There we go. Hopefully that's working now. So fortunately, Dr. Argote Green has been answering them as they come in. But one of the ones I want to highlight because it's a question that comes up frequently, and before we move on, I think we could talk about it. The question from Mary was, I had a CT scan for some abdominal pain, and it showed mild atelectasis, but I had not been sick or had any breathing problems. What could cause this, and should I be concerned? And Dr. Tabe, I was hoping you could address the question of atelectasis when it's seen on CT scans.
Sure. So atelectasis can just be an area of lung that's not fully opened up, or you weren't taking a deep breath during the CT scan. So definitely to your provider, it may be something that needs followed up on further chest x-rays down the road or further CT scans. It all depends on what they see. But it also may mean that you need to take deep breaths, cough, exercise, and do things for good airway clearance. I'm glad you're feeling well. That's a
Great. So now we're going to move on to talk about the diagnosis of lung nodules and the various methods that we employ to help get to an answer. At the end of the day, the question we're really trying to answer when we're addressing a lung nodule is this nodule cancer? And this process involves a lot of steps, but it really starts with a thorough history from the patient. asking about risk factors, performing a physical exam, and then based on what we learn from that, we move on to a variety of tests that help provide more information and hopefully will guide us to whether or not we need to proceed to a biopsy. So starting point is oftentimes an imaging study, and a lot of times folks have had this before they come to talk to us. There are different types of studies. Computed tomography or CT scans were covered by Dr. Teba, so we're going to skip over that, and I'm going to move on to positron emission tomography or PET scanning. And basically, the way a PET scan works is that a radioactive tracer is hooked up to a sugar molecule, and this tracer is then injected into your bloodstream. And we allow that tracer to circulate for about an hour, and then we put you through a scanner, and we're looking to see where did that tracer go. And areas of the body that are more active will take up this tracer and concentrate it. In particular, again, getting back to the question, is this a cancer? Cancer cells are growing out of control, and so they need a lot of fuel, and they need that sugar. So they'll take up this sugar linked to the tracer and concentrate it. And then when we put you through the scanner, we can see, did that nodule take up a lot of tracer, and that raises concern for cancer. Now, PET scanning isn't perfect. If the cancer isn't growing very fast, and some don't, it won't necessarily take up a lot of tracer. The alternative is that anything that leads to inflammation, so infections, particularly in the lung, will cause the tracer to be concentrated in the lung as well. So the PET scan is another piece of information that tells us, pushes us one way or another towards, is this more likely to be cancer or is this less likely? So those are probably the main modalities that we're looking at. Here in Cleveland at University Hospitals in Case Western, there's a number of research projects that are ongoing. These aren't quite ready for clinical use yet, but I think they're exciting and hopefully will inform how we manage these nodules in the future. At Case Western, Dr. Matabushi is applying machine learning technology and looking at the radiomics of lung nodules. In CT scans, there's a lot of data that's collected digitally, and that data is then used to generate a picture which the radiologist looks at and tells you what they see, and that's where we find the nodules. But there's a lot of data still embedded within that the eye just can't pick up, and that's where the evaluation of these this additional data can be informative as to whether or not the nodule is more likely to be cancer. Again, this isn't quite ready for clinical use yet, but it's an exciting area, and we're hoping that in the next couple of years, this is going to be something that'll add to our ability to determine the likelihood of cancer and hopefully avoid biopsies in patients who don't require it. Same goes for dual energy CT. The head of our thoracic radiology group, Dr. Gilkison, has been evaluating this, looking at how much iodine from the contrast gets into a lung nodule. And nodules that have that are more likely to be cancer will develop a blood supply as they grow. And so they'll have more of the contrast in them, whereas scarring from prior infections and things like histoplasmosis will not have that blood supply, and so they won't take up the iodine. And this image here shows two nodules actually in the same patient, and what they found was that one nodule had additional iodine in it, and that turned out to be a lung cancer, whereas the other nodule, which was actually larger, didn't have any uptake, and when it was biopsied, it turned out to be histoplasma. So again, this is an area that's currently undergoing research, but hopefully will be available for clinical use in the next couple of years. So now, once we have the imaging, that tells us a lot about the nodule, but it doesn't tell us really about the patient. And so we need to take into account other factors that Dr. Teba had mentioned, such as smoking history, gender, family history of lung cancer, whether or not emphysema is present. And we use all of those characteristics of the patient to come up with a likelihood that the nodule we're seeing could be cancer. There's multiple prediction models, and they all have sort of varying pros and cons. The one that we probably use most commonly now is the Brock model, which was developed based off of the population of patients in the National Lung Screening Trial. So it's really designed for high-risk patients with a big smoking history, but it does a good job of telling us the likelihood that a nodule we find during a screening study is cancer. And for low-risk nodules, we're going to just continue to observe. For high-risk nodules, a lot of times that the likelihood that that's cancer is pretty high, and so we may, bypass a diagnostic procedure and refer those patients directly to someone like Dr. Ogote-Green just to have them removed because we're so worried about cancer. But in the middle is a group of patients who the nodule is worrisome, but it's maybe not so worrisome that we would just immediately go to have it removed. And those patients are a little bit harder to figure out what to do with. I mentioned blood tests because that's a question I get asked fairly frequently in clinic is, whether is there a blood test that can tell me if I have cancer, or how come you're worried about cancer? All my blood work was normal. And unfortunately, the answer is probably not really. Blood tests aren't terribly helpful. That being said, there is one commercially available blood test that can give us a sense for whether or not the nodule is malignant. And really, this test, it's called Notified Lung, requires a blood draw, and they're looking for specific proteins in the blood that are associated with lung cancer. And for people with intermediate risk nodules, depending on whether or not those proteins are present, we can either downgrade their risk to low risk, in which case we would continue to follow them with imaging studies, or it can indicate that they're high risk and then we need to move on to either a biopsy or straight to removal. Which kind of takes us to our next step, biopsy. At the end of the day, when a nodule is concerning enough, the imaging will only tells us so much. And if there's questions, or if we need to know what it is, we need to get a piece of this nodule and have the pathologist look at it under the microscope and tell us what they're seeing. And so there's several ways that we can approach this. The first method is an image-guided biopsy, most commonly a CT-guided biopsy. And what happens is the patient ends up lying on the table in the CAT scanner, and the radiologist will put them into the CAT scanner, identify where the nodule is, and then line up a needle. And after giving the patient some medication to make them a little bit sleepy and some numbing medicine, they insert the needle in between the ribs and under guidance from the CAT scan directly into the nodule to get a biopsy. This is actually quite an accurate way to get an answer as to what's happening in the nodule. The literature suggests that the diagnostic yield is about 90%, so it's quite good. But unfortunately, some of that varies depending on the size of the nodule and in addition, its location. The further away it gets from the chest wall, the harder it is to actually guide the needle into it, and so the diagnostic rates will fall off a little bit. The other part of it is that CT-guided biopsies, putting a needle into the lung, carries with it some risk, and the main risk is to collapse the lung. This happens somewhere between 25 and 40% of the time that this is done, and about 5% of the time the patient needs to have a tube put in between the ribs to help the lung reinflate. So again, CT-guided biopsy is a good method, but it does have some drawbacks. The other thing that doesn't necessarily occur with a CT-guided biopsy is there's no ability to evaluate the lymph nodes in the center of the chest. And when we're concerned about lung cancer, one of the main questions that we need to answer in order to appropriately stage somebody is whether or not the lymph nodes are involved. And that's an important question because it really dictates what kind of treatment they're going to get. So even though we have an answer from a CT-guided biopsy, patients often require an additional procedure so that we can bring together the whole picture of what stage they are and get them to the appropriate treatment. So another method for obtaining a biopsy is through something called a bronchoscopy. And a bronchoscope is essentially just a camera on the end of a long flexible tube. It's about the size of your little finger. And this tube the camera is inserted either through the nose or the mouth, down the throat and into the windpipe, the trachea, and into the lungs. And then using different tools to assist, such as fluoroscopy, or more recently, there's new technology that allows for almost like a GPS type system to guide the bronchoscope out to the lung nodule. We take a biopsy from the inside. And it's a little more difficult. So the diagnostic yield from a bronchoscopy is about 70%. But it comes with a better safety profile, and the risk of collapsing the lung is only about 1 to 2% with bronchoscopy. Because it's oftentimes not as well tolerated to have a camera go down into your lungs, we're doing a lot of these procedures now under anesthesia. The other benefit of bronchoscopy is that the evaluation of the lymph nodes in the chest can be done at the same time. And the advantage there is that patients only need to undergo one procedure to get a diagnosis and to have their lymph nodes evaluated so that we can come up with the appropriate stage and get them to the correct treatment for them. This is a slide just showing what a bronchoscopy procedure looks like. Nowadays, it's really a team approach. There's the pulmonologist or thoracic surgeon doing the procedure with several assistants. There's an anesthesiologist who is making sure that the patient is asleep and comfortable and safe throughout the procedure. And then more recently, and something I'm actually quite excited about, is robotic bronchoscopy. This has been available on the market now for about 2 years and represents a huge leap forward in the technology for the ability to get to lung nodules way out in the lung and to get a biopsy. I'm very excited to say that University Hospitals has just reached an agreement to bring this technology here, and we should be launching it for patient use in February of 2021. The exciting thing about robotic bronchoscopy is that it's much more accurate than our current systems, and our diagnostic yield, at least in early studies, looks to be almost, if not as good as a CT-guided biopsy. So we're achieving diagnostic yields of about 90%, but while maintaining the safety profile that we traditionally associate with bronchoscopy, such as complication rates in the 1 to 2% range, with the additional benefit that if it is cancer, the staging can be done at the same time as the bronchoscopy. Again, saving patients multiple procedures and sort of expediting their movement through the system and getting them to the appropriate treatment in a more timely fashion. So lastly, there are some nodules that really ought to just come out, and that's where surgery comes into play. And Dr. Argote-Green is going to talk to more in depth about that, but it's something that definitely needs to be considered. And after going through all this, I think I'm trying not to make this overly complicated, but it is a fairly complicated assessment of both the characteristics of the nodule and of the patient and determining what's right for them. And because of this, we find that it's better to get together as a group and use everyone's expertise. So University Hospitals Cleveland Medical Center has a lung nodule board that meets weekly. And this includes experts on lung nodules from pulmonary medicine, thoracic surgery, and thoracic radiology. And we review the scans of patients with high-risk findings and make recommendations on what's the best way to approach the next steps, whether that's continuing to observe with radiology studies, proceeding to some sort of biopsy procedure, or again, directly going to surgery to have it removed. And it's a nice feature that we're able to offer to patients, and we make recommendations back to the ordering physician, based on the group's assessment of the nodule and the patient. So with that, I'm going to go ahead and turn things over to Dr. Ogotte-Green, who's going to talk about surgery and curing lung cancer with minimally invasive surgical techniques.
Hello. Great. Let me see if I can share my screen. There, perfect. Okay, so it's a pleasure to be here with you. I really appreciate participating with great partners, Dr. Tiba and Dr. Ben Young. Appreciate for the marketing equipment team, I'm sorry. And turn this off right here a little. Hello, hear a lot of, there. Hello, so it's important to talk about the minimally invasive surgical techniques. Before, a lot of patients would get very concerned about having surgery, and they think about these huge incisions they used to have in the past. And so nowadays, lung cancer has shown to be the leading major cause of cancer death in men and women in all ethnic groups. And that has really have an impact in how we deal with it. Lung cancer has shown to be more common, and there's more lung cancer deaths compared to even if you put colorectal, pancreatic, breast, and liver cancer together, you still have more deaths from lung cancer. So that's an important point. And a lot of these patients are former smokers, like 60% of the lung cancer patients are smoking at the time, but also 20% they quit smoking already. And there's 20% patients with lung cancer that had never smoked. Lung cancer has overtaken breast cancer as the main cause of death in women. So that's important. It's an important cause of mortality in women nowadays. I won't go over this. Dr. Tiba already talked about this, but lung cancer rates are declining right now because people are not smoking as much. But an important reason to do all these screening programs is that when we find lung cancer or little nodules that are early stage lung cancer, they can be cured. In the past, they used to say, well, if you have lung cancer, you'll die from lung cancer. But nowadays, that's not true. When you find these little tumors that are 1 to 2 centimeters here in the top right corner, you can have a cure rate of up to 80, 85%, almost 90% when they're smaller than 1 centimeter. So those are the lung cancers we're treating nowadays. And when I started my medical training, we rarely found these cancers, but nowadays we're really curing lung cancer. As you can see, if you find a stage 4, that's a very advanced lung cancer, the survival at 5 years, it's really low, it's less than 5%. So evaluating lung nodules is a specialized endeavor that can be done by a medical team, as Dr. Tiba and Dr. Ben Young have discussed. And we usually use CAT scans, we use PET CTs, we evaluate different risk factors. And if it's a suspicious lung nodule, then we go on and do a biopsy of some sort. Sometimes you just have to lay down, you get a needle placed in it. Sometimes we put a little scope in your chest, through a tiny 1 centimeter long chest incision. And those are the minimally invasive techniques. So the idea, I promise this is the last picture like this I play. So is not having these huge surgeries you used to have in the past, but having these tiny little incisions. And through those tiny incisions, we can do what before it was done through big incisions. These little nodules are so small that sometimes even touching them is really hard. So we use different methods to locate them, like putting a wire in them, using radioactive markers, using ultrasound, or using something that also Dr. Ben Young uses, which is navigational bronchoscopy. The post-operative course, you don't have to stay 1 week in the hospital anymore. That's not the common thing. Usually you get 1 to 3 incisions when you get, let's say, a wedge resection, which is like a triangular shaped resection. We use the staplers that staple and cut at the same time. So they're pretty nifty. They have really improved our outcomes. And then you stay in the hospital for usually one night when you do wedge, and then the chest tube gets removed the next day, and you leave the hospital the next day. You're back to work usually in 1 week if you want to go to work. And then the diagnosis you get, it's pretty safe and effective and efficient procedure. You get the results in more than 99% of the times. The conversion to open is less than 5% when we can't find it for some reason. Complications is less than 2%. The mortality, it's pretty low, so it's a pretty safe surgery. Sometimes doing a wedge resection like this one here can be equal to cure. Nowadays, we're doing lesser resections, just like in breast cancer. A few decades ago, they would do this very large resections, remove the whole breast. Nowadays, we're removing only one small area of the lung, like a little triangular shape. That might be enough cure, especially in older patients. So the question that, and what we discuss in clinic when we do these types of surgeries is, if it is a cancer, then will we cure it with a wedge, with a segment, which is a little a larger incision than the lobectomy? All of them can be done through open surgery or minimally invasive surgery. Of course, we always try to do the minimally invasive surgery. And I'll show you some data of why UH is a great place to have surgery. We also use robotic techniques. This is a picture of the robot. The only part that goes into the body is the tip of these arms. We have 4 arms. It's like having your hands in there, like having 4 hands in there. So it has, that's the future, and the future is here. So we have multiple. I won't go over all these letters. Don't worry about it. The important part is that surgery offers improved survival. The studies that we used to have in the past, which is a study called Lung Cancer Study Group, that's a study that is 30 years old. So that's why nowadays we're not doing lobectomies in everyone. We're doing smaller surgeries, more, we try to save lung so you can breathe better. And of course, this is always discussed with you, and the reasons to doing all these different types of procedures. Other local therapies, in case you have a very bad emphysema, we talk with our colleagues. We have a very tight multidisciplinary discussions on when it's a good time to use other types of radiation, of ablation that Dr. Ben Young also treats. But we have a lot of tools in our toolkit that don't specifically have to be surgery. So VATS, or minimally invasive surgery, VATS means video-assisted thoracic surgery. It's a new standard for surgical resection, and it offers less blood loss. We have minimal blood loss, usually less than 50 cc's. The hospital length of stay is much less post-operative pain, and some studies suggest we have better 5-year survival, which I agree. And robotic surgeries get rapidly gaining acceptance, and I think that's a future. So we're doing it now. So why at UH? Well, UH is near the top 10% of all major academic medical centers in regarding lung resection according to the Society of Thoracic Surgery National Database. And we have consistently had shorter lengths of stay, and we have a consistent lower perioperative mortality for major lung procedures compared to other major academic medical centers. So we have pretty good results. This is one of the examples in the academic medical center benchmark. The mortality is 3.5%, and our mortality is 0.7%. Our median length of stay, that's in all the patients. Doesn't mean that you're going to stay 7 days in the hospital, but in all the patients that we manage, which sometimes we have pretty sick patients, so our median length of stay for all of the patients are 7 days, but in the benchmark is 10 days. So we're better than the benchmark. And the median length of stay, we're also almost half the benchmark for academic medical centers. And we have 35% less decrease, lower than average mortality compared to other medical centers. So I really appreciate your the opportunity to talk to you.
Thank you. We're going to turn this back over to Dr. Young, I think, to help moderate some of the questions that are still coming into the Q&A. And I know a lot of them have already been addressed as well, but I will say that if you want to touch on any of those you're seeing in there as well, Dr. Young, again, feel welcome to do so. I have a couple questions that we received in advance, so I am just going to hit those briefly. So the first question was, my mom has lung nodules along with severe emphysema. Is she at higher risk for nodules becoming cancerous? And can you talk about how lung nodules and emphysema relate or impact each other?
That's a great question. I think given that Dr. Teba addressed the imaging findings in lung cancer screening, I think I'll turn that one over to her.
Hi there. So emphysema and lung nodules. So the emphysema sounds like she was a smoker and likely a significant smoker. And so the smoking pack year history puts you at risk for the emphysema finding on the CT scan. And the emphysema finding on CT scan may mean that she has COPD. And then the second part of that question, I believe, was does emphysema and lung nodules go together? It just depends on what kind of lung nodules are. So sometimes you can have lymph nodes in the lungs called visceral nodules. So those would be consistent with benign. With the smoking history, if they're ground glass, if they're larger, those are more concerning for developing into lung cancer. But if she does have the smoking history that we talked about, the 30 pack years, if she quit within 15 years, or if she's still smoking, she may benefit from lung cancer screening moving forward. Does that answer the question?
Yes, thank you. And then the other question that we received in advance was, I've been diagnosed with histoplasmosis from chest x-rays. And how was the diagnosis determined without a biopsy of the encapsulated nodules? This individual says they've never been exposed to known causes like bird or bat droppings, but worried that it could be something else. So can you diagnose histoplasmosis with high probability from an x-ray, or are there additional tests to positively determine this diagnosis?
So if there's active signs of infection, there's testing that can be done. Most likely the imaging suggests history of histoplasmosis, which we sometimes discuss if there's calcified granuloma changes causing nodules on imaging, chest x-rays or CT scans. It would be just the clinical diagnosis or clinical suspicion, nothing that could be 100% ascertained just looking at imaging.
Yeah, I think the key here is really the quality of the imaging studies. I would be a little reticent to diagnose histoplasmosis off of a chest x-ray. There are radiographic hallmarks on CT scan. And so you're pretty comfortable in those situations saying that this is most likely histoplasmosis. In the acute setting, there are some blood tests that can help to sort that out. But I guess at the end of the day, I would be, again, hesitant to do that based off of a chest x-ray alone.
Okay, thanks. And then Dr. Young, do you want to go to the Q&A and see what you're seeing there?
Sure. I think I'm going to ask Dr. Argote-Green to weigh in on this one. We got a question from Denise, who had a calcium scoring test earlier this year that found a 5 millimeter nodule. Subsequent CT scan was done, and it sounds like the plan is for a recheck in about a year. The scan showed the nodule to be in the right middle lobe and said it appears to be a linear density along the minor fissure, probably a fissural nodule or thickening. Could you comment on what a fissural nodule is?
Yes. So fissural nodules are usually benign. They're rarely malignant. Sometimes there's some inflammation in the fissure. The fissure is the division between the lobes. It's the right lung has 3 lobes, and the border, the margin between those different lobes they're called the fissures. So sometimes when you see this tiny little linear scarring areas, they're rarely malignant. That's so we usually don't worry about those. And now the screening, the CT scoring for calcium for the heart only shows the images where the heart is. So we still miss a lot of the chest. So if you have a high risk factors, I think you should undergo a real CT screening for lung cancer. And if not, I would not worry about that tiny 5 millimeter nodule, especially if it's in the fissure. But of course, you always have to go with a team that evaluates all the risk factors and then says this is worthwhile to have this CAT scan, which they're all low dose. When we do a screening for lung cancer, we use low dose CAT scans. That's important because a lot of people are worried about how much radiation am I gonna get, and radiation for this in this type of CAT scan, it's a very low dose.
Thank you, Luis. There's another question here addressing tree and bud nodules. And I think, Dr. Tabe, I'm going to ask you to comment on this one again. I was recently diagnosed and being monitored by my pulmonary physician for tree and bud nodules. These were first discovered by my ophthalmologist due to differences in pupil size, possibly Horner's syndrome, and followed up with brain scans, carotid artery tests, and ultimately biopsies, revealing the tree and bud diagnosis. Should I seek a second opinion?
Very good question. So tree and buds are usually a radiographic diagnosis or description. It's basically just what's seeing on the CT scan, which looks like a spring tree branch budding little tiny spring buds. So usually it's described based on CT scan findings. The biopsies sometimes, or the cultures from bronchoscopy will sometimes reveal inflammatory infectious diagnoses. The pathological diagnosis of tree and bud I've never heard of. So I just question what the pathological diagnosis really was from the biopsies. Perhaps it was just inflammation that was going along with the tree and bud findings on CT. So maybe just clarify with your doctor, your pulmonologist, and if anything's continuing symptoms, etc., we'd be happy to see you for a second opinion. Thank you.
No, I think that's a good summary. In general, when it comes to second opinions, if you think you need one, go for it. You know, it's never wrong to ask more questions. So our next question, and Luis, I think I'll throw this one back to you, is my oncologist this week was not able to answer my questions regarding newly found lung nodules. I have sarcoma, and are sarcoma nodules in the lung generally biopsied first, or is the first line of action to surgically remove them? Are nodules in the lower lobe or upper lobes more concerning? And at what size do sarcoma nodules become particularly concerning for biopsy or removal?
Well, that's a great question. And, you know, with a history of sarcoma, it's always important to have very high suspicion for what could be a metastatic spread. That's important to know. Now, it doesn't mean that you can't have nodules for other reasons, but you need to be aware that that could be a potential possibility. There's a big discussion about how many nodules and can you resect them all. So if you can offer, no evidence of disease after resecting them, that might be an option. Because if you prove that the patient has a recurrence, then you can discuss about extra treatment, chemotherapy, radiation, whichever that is, usually chemotherapy. But that has to be closely discussed with as a multidisciplinary team and what the plan is. And it depends on where they are, how many they are, and I've worked in several centers where we try to resect metastatic disease as long as it's feasible and it's logical. But I think it's something that has to be discussed as a team, especially with the medical oncologist, that specializes in sarcoma.
Great, thank you, Luis. Another question, and this one, Dr. Taba, I'm going to direct to you. CT scan found a 3 millimeter anterior left lower lobe nodule with mild bibasilar atelectasis. What does this mean, and should I have a follow-up?
So the question for follow-up is, you're a smoker, you unlikely need follow-up. If you're a heavy smoker, you may warrant follow-up with your imaging scan. This just means an area of lung that's not inflated, an area of lung of collapse. Sometimes it can also be from an area of lung that's scarred and it's not gonna inflate. So talk to your doctor, talk to a pulmonologist to see where you lie and what your history is and what your follow-up should be.
Great, thank you. Another question is, I had radiation for breast cancer 15 years ago. My cardiac scoring showed lung nodules typical with scarring. Could that be from the breast radiation? I think I'll start with that one, and if you guys want to jump in as well. Radiation for breast cancer is typically done in a fashion so that a very small amount of lung tissue is exposed to radiation. It's pretty classic on chest CT that it's very anterior towards the front of the chest, right underneath the ribs in the area that was irradiated. Now, this could show up in the calcium scoring CT. And so if that's what they're referring to, then it is quite possible. It'll also be on the same side that the radiation was done. So that's an important factor. If it's on the opposite side, it's not related. So I guess it really depends. Nodules and scarring can be due to the radiation, but it just, the exact factors associated with that nodule would need to be evaluated.
And it's also very important to notice which side it is. 15 years ago, you might have not had the equipments we have nowadays. So it depends on what type of equipment they use to do the radiation. So we have seen an increase in the number of malignant lung nodules or lung cancer in the site where you had the radiation. So radiation can predispose you specifically on the area that you got radiation for some type of malignancy. So it has shown to increase the happening of lung cancers there.
Great, thank you. Next question. I have, and I'm going to ask the whole group to weigh in on this one because it's not straightforward. I have sarcoma as well as Wegener's granulomatosis. My last 3 CT scans show growing size of lung nodules, it sounds like with calcification. So we decided to treat with Rituxan infusions in hopes to reduce the size of the nodules. Would you care to comment? And as I said, this is a complicated situation. Both sarcoma and Wegener's can result in nodules in the lung, and it really comes down to what are you trying to treat. And this, I think, really probably best is served by a discussion with your oncologist, between you, your oncologist, and your rheumatologist, to determine what what's actually going on there and the appropriateness of Rituxan treatments. I'm not as familiar with Rituxan for sarcoma, but it is not infrequently used in granulomatosis with polyangiitis. So it may be the appropriate treatment for lung involvement there.
Agree with you, Ben. Sounds like they're trying to treat the Wegener's,
I think,
and these are not related to the sarcoma. So definitely a discussion with your doctors.
Yep. All right, next question. How large do lung nodules need to be considered suspicious of cancer? Dr. Tabor, do you want to comment?
Yeah, thank you. So great question. So this all depends on your history. So if you were a heavy smoker and you have a small lung nodule, it really could consider follow-up for that. So even a small lung nodule, you could consider a follow-up in a year. And then if it's changing, it may need closer follow-up. If it's not changing, you may still need another follow-up in a year. And it depends on if it's ground glass or solid. So if we have a CT scan today, you've never had one before, and we find a nodule solid 1 centimeter or more, it's more suspicious for cancer at that time. But then the follow-up is what's important. Is it changing? What does it look like? If you had the CT scan today, is it suspicious for cancer? Is it a lung nodule that it's in an area suspicious cancer? Smokers who have heavy pack-year smoking history and have an upper lung zone predominant lung nodule with those speculations and concerning findings. Even small lung nodules can be cancer, unfortunately. And so that's why we do lung cancer screening to find lung nodules when they're small, know what they're changing, and know when they're changing to take care of them sooner rather than later. But in general, if we just found it, more than 1 centimeter is concerning.
Great, thanks. We're starting to run over a little bit on time, so we've got one more question that we'll answer, and then we're going to wrap things up. So the question is, I had a CT scan last month, and there are lung nodules present. I also have sarcoidosis that was diagnosed about 10 years ago, and severe allergic asthma. Former smoker, half a pack a day for 20 years, quit 10 years ago, and my paternal grandfather died from lung cancer. How often should I follow up on my nodules? And I guess I'm going to start by saying, definitely discuss this with your pulmonologist. If you don't have one, you should. And the follow-up on the nodules really depends on the size. So when we look at nodules, they're basically, as Dr. Tabor was just saying, the larger they are, the more likely they are to be something concerning. Now you have several other things that could also lead to nodules in the lungs, such as the sarcoidosis and asthma, particularly if it's acting up or there's mucus impaction. That can also lead to some nodules on a CT scan. So unfortunately, my answer is it depends, but this is a good question for a discussion with your pulmonologist.
Thank you. And thanks to all of our speakers for sharing this information today and answering the great questions that were posed by the audience. As a reminder, at this point, we will email a link to view a recording of this session on our website once it's posted. And any of our specialists that spoke today are taking appointments, and you see the phone number there on the bottom if you'd like to schedule an appointment with one of our providers. This concludes today's session, and thank you for attending. Have a great afternoon.